sarcomas are not one monolithic disease, that there are lots of different kinds of sarcomas. How should a physician approach a patient with a sarcoma of soft tissues?
I'm absolutely convinced that treating sarcoma as a whole entity is absolutely not justified anymore. We absolutely need excellent pathology diagnosis accompanied by molecular diagnosis, if appropriate, in order to find the best possible therapy.
And Europe, the US, and Asia just worked together on an international study of eribulin. And eribulin has been around to treat breast cancer, but that study only had leiomyosarcomas and liposarcomas, and US FDA just approved that drug only for the liposarcomas. So that's going to be interesting to see what happens in Europe, but it's getting doctors thinking about liposarcomas, leiomyosarcomas, GIST as very different diseases, which I think is a good thing.
Absolutely true. Also, an increasing number of studies are only focusing on specific histiotypes, and this is clearly necessary. Some of the older studies clearly have some problems because they included all subtypes. For treatments we now know are less optimal for some subtypes. Still, the result is analyzed for the overall group, and thereby we might well miss activity for some drugs or combinations for some subtypes, or overestimate activity in other subtypes. So we clearly need to move on to specific studies targeting specific histiotypes, which becomes obviously a question of numbers. The rarer subtypes can only be studied in pan-European, or even better in global studies, involving all experts from all over the world, coming to results in a reasonable period of time.
So we're hearing a lot about how well people have done with GIST, but we still have problems with resistance to the current targeted therapies. So one of the issues is more mature data show that maybe up to 20% of people still have disease control and are alive after more than 10 years, which is encouraging. But that also means that 80% or so have had failure of the drugs. How should we manage to tackle resistance, Peter?
Well, I think we reasonably well understand how resistance develops. The majority of resistance, secondary resistance, is based on the development of secondary resistance mutations. We still cannot finally answer whether these secondary resistance mutations are present from the beginning. If yes, it would only affect single cells, and even with deep sequencing we are still not able to detect single cells. So this answer remains still open. Nevertheless, there are a couple of strategies to address the development of secondary resistance. Still too early to draw conclusions, but at least that's an interesting concept. The other possible concept is to use steel surgery to remove residual disease. This has been analyzed extensively in retrospective series. 2 randomized studies have been undertaken. One was stopped very early in Europe. Another one was also stopped prematurely in China, but at least gave some hints that resection of a residual disease may be beneficial on the long term, very likely because it obviously prevents those lesions to develop secondary resistance once they are taken out.
Peter, we hear a lot about discrepancies between Europe and the US, or even discrepancies inside Europe between different countries. I think more and more with the internet and with our global meetings, I think we're getting closer together to having a more consistent pattern of care amongst the experts, possibly not between the experts in all the different communities. My experience in the US is that there still is a challenge for many doctors who do not see a lot of sarcomas to know exactly what to do with them, because we are becoming much more specific about our therapeutic options for different types of GIST and different types of sarcomas. Whereas my practice, your practice in Berlin might be more significantly similar, because people who see a lot of these diseases tend to have more similar practice patterns. What's your sense of how that is in Europe?
George, that is absolutely true. There are some underlying differences, but the general approach within expert groups, I think, is not so different. We share probably the same problem as you do, that there is a huge gap between experts and not experienced people treating sarcomas. We shouldn't forget it's still a very rare disease, accounting for approximately 1% of solid tumors in adult patients. So general oncologists obviously have a lot of experience in colorectal, breast, lung, prostate cancer, but they very rarely see sarcomas outside a dedicated center. So this is the main issue, and that is probably absolutely comparable between US and Europe.
I also feel that this meeting is one of the first where the experts are also talking about the value of the drugs. We're setting a higher bar for ourselves about what kind of therapeutic impact we need to make to really have it be worthwhile for our patients. And one person very clearly, Wynette van de Graaff, said very clearly, we need to have the patients engage with us to tell us more their perspective. And I think that's a very healthy discussion as well.